Well, you guys, thank you so much for inviting me to talk to you guys about, a topic that's very close to my heart, and that is skin cancer. I'm Dr. Ben Wise, and yeah, let's start our learning together. So who am I? Ben Wise. I'm originally from South Africa, trained at the University of Pretoria, close to Johannesburg, and we then very early on in our careers realized that there's a gap in our skin cancer knowledge. Specifically, when I was working in oncology and plastic surgery, I did some calls for them while in South Africa, and that's of course where our journey started with self-education. I am finishing the semester my master's degree in skin cancer through the University of Queensland, an absolutely amazing program for the physicians that is joining us tonight. I would highly recommend the program, especially if you have an interest in skin cancer. Good. And then a lot of times patients would ask me, how does my clinic look? And I just want to show you guys how a skin cancer clinic actually looks. So I'm just going to show you guys a short video of our clinic. Perfect. There we go. So just a little bit of how our clinic is looking. And then what we will be discussing tonight. First of all, what is the big fuss over skin cancer? Are there different types of skin cancer? Who's at risk? How do we clinically diagnose skin cancer? What type of biopsy types do you get? Diagnosis, what is in a name? Probably the first thing that patients ask me, when I diagnose them with skin cancer is, will I die? And what are my treatment options? Which I think is a very fair question. And then the last would be, I never want to repeat this ever again. How can I prevent it from happening? So yeah, so we're gonna touch on all those points tonight. And yeah, hopefully we will leave here a little bit more knowledgeable, and hopefully I can help you guys to better understand this quite complex topic, but fascinating indeed. Okay, so what is the big fuss? So first of all, of course, it is a big fuss because one person dies of skin cancer in North America every hour, which is crazy. More than 80,000 people are diagnosed with skin cancer every year in Canada. And skin cancer is the most common cancer of all cancers in the world, which is just unbelievable. I think these statistics always makes you, cringe a little bit. It's definitely something that all of us should know something about. You get variations of skin cancers. The patient here on the left, I always say this patient, or both of these patients, fell through the cracks. One can really see, so this patient's got a small basal cell here at the top, a melanoma here on the upper back, and then he's got another melanoma on his right lower back. And then what is really interesting is also to see all these other skin lesions, all these moles that he has. These are all normal. And I think sometimes it's so difficult to know what is normal, what is abnormal, specifically on our backs. It's a really difficult area that we can't see. The older we get, the more difficult it is to look at our backs, even using a mirror. And of course, this patient, here we can see he had already quite a few excisions done. And every lesion that I've encircled here, these were all skin cancer. And I always tell patients, this is the time that you don't want to see a patient, or this is a patient that should have presented much earlier on. So this is an example of somebody that fell through the cracks. We can also see this darker pigmentation area. This is a patient also that had radiation. So probably a complex medical patient, but again, for whatever reason, I think we forget about the skin, or sometimes physicians, we forget about the skin. We think about other organs as more important, but skin cancer, of course, very important. We want to see you and we want to help you before you have all of this. But luckily, these are exception on the rules. Then the types of skin cancer, I know that this is the melanoma network, but I think it's important to also know about the non-melanotic skin cancers. The first one is basal cell carcinoma. And you get two types. You get a non-aggressive basal cell, and then you get an aggressive basal cell carcinoma. So your non-aggressive basal cell carcinomas are nodular and superficial basal cell carcinoma. And I always say these two cancers are my favorite. It's easy to treat. You don't necessarily have to surgically remove it. You can use some topical medications for it as well. They're very forgiving. They're very slow growing. So that's why I always say these are my favorite cancers to treat, just because it's so easy to treat. If we have a look, I just want to show you guys this video, and this is just to show how sneaky skin cancer can be. So as soon as you move the hair away, there is a basal cell carcinoma that is hiding. So I just wanted to show everybody just how it can hide. And this is the basal cell that was hiding under the hair. So as soon as you move the hair away, you could see this basal cell. And this was a nodular basal cell carcinoma on the forehead. The one on the right, this is a superficial basal cell cancer. It's red, it's increasing in size, it itched a little bit. This patient thought that it was psoriasis, even though she was never ever diagnosed with psoriasis. So when you have something on your skin that's new, that's changing, it's enlarging, immediately this is where we start thinking about skin cancer. Sometimes it's very difficult if you have had psoriasis or eczema in the past, because then it's sometimes difficult to know what is psoriasis, what is contact dermatitis, what is eczema, and what is skin cancer, specifically the superficial basal cell carcinoma type. Again, this is a large lesion. We treated it with photodynamic therapy. We didn't have to surgically remove it. She responded well to the treatment, and yeah, is cured or was cured, but luckily didn't need any surgery, which was really good. The next patient, how many cancers can you see? So have a look at this photo. I'm sure you guys will, there's a very good chance that you will find at least one. So have a look. Okay, so of course, let's go to the next slide. There's the other guy. So if we go back, we can immediately see there. So this guy, of course, is very easy to see. You don't need any special microscope or anything to see it, but there is another basal cell carcinoma that is hiding there. So there we can see it. So these two in close proximity, they're not related. This is not a metastases or anything like that. This is just a second type of basal cell that you have combined with that guy. And then if you look under a microscope, and we'll talk about this a little bit later, dermoscopy, this is where you use a specific piece of equipment. It's almost like a microscope that gives you a picture, and this is how a basal cell carcinoma, this is how it looks under the microscope. It's got these very fine, we call these arborizing blood vessels, these black clots This is an area of ulceration. So these are all, when I look at this, I can immediately tell the patient, hey, this is probably a basal cell carcinoma, and these are our treatment options. This is the other one. This was the raised lesion on the right-hand side. Again, these blood vessels, that's very superficial. They're nice and thick. They almost looks like the roots of a tree. And then you've got these gray, black type of black clots. And then these brown pigmentation areas are all indicative of a basal cell carcinoma. Absolutely beautiful when you can see it this way. But then also you get your aggressive basal cell carcinomas, and these are your micronodular, infiltrative, morphea, metatypical, and basosquamous. Now, this is where I tell my patients basal cell cancer is my favorite cancer, but there is a but, not these. I don't like them. The reason is that you really need to make sure that you treat them well. You need to have a certain amount of normal tissue around the lesion that you're removing to make sure that they don't reoccur. The other reason why basal cell carcinoma is my favorite cancer is because they don't metastasize, they don't spread to the lymph glands. But there's one exception, and this is the basosquamous type of skin cancer. This one can metastasize, tricky to treat, and this is, if you've had any of these, it is important that, or if you're going to have something like this in the future, you really want to make sure that you get nice wide margins around it, and also make sure that you're treated with somebody, you know, experienced with dealing with these type of lesions. You can't also, you can't use any topical treatments for these. They need surgical treatments, and especially if it's on the face, ears, scalp, this is where you really probably will need Mohs surgery. And again, if you go onto the Melanoma Network's website, they talk about Mohs surgery, so you'll see, you know, what I'm talking about. These are examples of basal cell. This is a basosquamous, so this is a large lesion. I mean, this is 15 millimeters on his nose. The lesion was primarily removed. He already has seen radiation oncology, and I also referred him for Mohs surgery. We will first do Mohs surgery, and then there is a chance that he might need radiation as well. This is on the back of a patient's ear, and this is an infiltrating basal cell carcinoma. Now, interestingly enough, the patient didn't know that he had this. It was only when he woke up one morning and found that there was some blood on the pillow that he realized that, hey, there's something here, because skin cancer is asymptomatic most of the time. You can't feel it. It's not painful. And it's only if you look for it that you will find it. And then, of course, the next type of skin cancer, so we're done with basal cell carcinoma. The next is actinic keratosis and squamous cell carcinoma. Now, actinic keratosis is also referred to as a pre-cancer, and that can be a little bit of it's a little bit of a misnomer. There's nothing pre-cancer about actinic keratosis. It is, you can almost think of actinic keratosis as it's a lesion that's on its way in becoming squamous cell carcinoma. And squamous cell carcinoma is a cancer that we definitely don't want to sit on. It is a cancer that can metastasize, causes a lot of tissue destruction. So we really, really need to make sure that if we're at risk, that we treat you as well as possible. Now, specifically your actinic keratosis, we get those due to long-term UV exposure, and it's typically on the face, the ears, the upper part of the bald scalp, and the back of the hands, the forearms, that typical farmer tan, or probably more these days, the golfer's tan, especially here in Kelowna and the Okanagan, where we all live to play on our beautiful golf courses. So these are the areas that's typically exposed to UV light, and that UV radiation causes DNA damage. And then what happens is there is that 8 to 20% chance of this actinic keratosis changing into a squamous cell. Now, an actinic keratosis, there's three things that can happen. First of all, it can either regress. So this is where your own immune system will luckily recognize it and it will cause it to go in remission. Or it can persist, where it's almost like a 50-50%, so it's almost 50% of your immune system is keeping it under control, but 50% of the actinic keratosis is also active. Or it will progress. And when it progresses, that is where it becomes thicker, and then it changes into a squamous cell carcinoma. Because the next point is very important, most squamous cell carcinomas developed from an actinic keratosis. So not all actinic keratosis is going to change into squamous cell, but most of the squamous cells that we remove, those came from actinic keratosis or precancers. And that's why it's so important that we want to treat those actinic keratoses. Field therapy is a really important treatment approach that one can use. This is where there's a few treatment options that we have available, something like 5-FU or Efidex or Imiquimod, Aldera, or the other two options is photodynamic therapy, where we use either Medfix or Levulan. All of them work really, really well, but there's no cure for it. So this means that, it's almost like a famous dermatologist in Toronto referred to it. It's almost like going for a dental clean. You can clean up the dental plaque. If you don't clean it up, if you don't go for the dental clean, once every 6 months or every year, then you're going to get those dental cavities. And it's exactly the same if you don't clean up that actinic keratosis, then there is a chance that you actually might get squamous cell carcinoma. So important to get treatment. A lot of patients would ask me, what about liquid nitrogen treatments? Because I'm sure that you guys that do have actinic keratosis all has had liquid nitrogen. I use gallons of it every day, but I always say, the question is, what do you want to achieve by treating these lesions? And especially if you have a lot, or if you have a field of precancerous lesions or photo-damaged skin, then the best is going to be to rather do a topical treatment option to make sure that we really stay ahead of these precancers not changing into squamous cell carcinoma. Actinic keratosis is like an undercover squamous cell carcinoma. So although sometimes there can be so many of it, there's nothing normal about them. They are that undercover squamous cell carcinoma. So actinic keratosis, here you can see these are very, very advanced actinic keratosis. This patient, should have been seen long ago. You can also see this redness. This is some broken blood vessels. These are all very, very advanced precancers. Also here on the ear, and he needed topical field therapy. This patient, not as easy visible. All you see is these red. There's one there that's a little bit more visible, that's standing out a little bit more, but otherwise all of this is all extensive photo damage skin. Somebody that loves being outdoors, and again, risk for skin cancer, specifically squamous cell carcinoma, is very high. This patient presented with a lesion on the tip of his nose, was concerned about it. And again, this is, if I look under the microscope, when I see this picture, immediately I know that this is probably a pigmented actinic keratosis. These almost look like honeycombing, so it's all these round circles, a lot of scale. So that white little spots that we see there, those are all white little spots. And if you really, really look closely, you'll see that within that little round circle, there's 4 little white dots, and we call that the rosette pattern. So it's 4 little dots in a circle, and that's highly indicative also of a precancer or an actinic keratosis. We didn't use photodynamic therapy on this patient because pigmented actinic keratosis doesn't do well with photodynamic therapy, the Medfix or the Levilan. We used Effidex on him, and he did really, really well. Then squamous cell carcinoma. This is a cancer that I really hate. I really don't like it. It's a dangerous skin cancer with metastatic potential. It is also the 2nd most common skin cancer. And this is a cancer that is due to cumulative sun exposure at a young age. So when we're exposed at a young age, and this is sometimes the difficulty, especially from a generational point of view, that a lot of us were exposed when we were younger. I mean, that's water under the bridge, and there's not too much that you can do about the past, but of course, there's a lot that we can do for the future. And when we leave these actinic keratosis, they develop into Bowen's disease or squamous cell in situ. That is the beginning phase. It's almost like the embryonic phase of a squamous cell carcinoma, and again, then it just progressively will get worse. There's different types of squamous cell carcinoma. You get well differentiated, moderately differentiated, and invasive squamous cell carcinoma. And as I've said, squamous cell carcinoma does have the potential to metastasize, especially if the tumor size is more than 2 centimeters, if they're thick, deeply invasive, recurrent, they've been treated, but they've come back, if they're poorly differentiated, if they have nerve involvement, because when they grow into the nerve, this is where they can metastasize, specifically also for areas around the ear, the lower lip, and if you're immunosuppressed. So immunosuppressed, these are the patients that I see, the organ transplant patients. That's the next point, specifically the renal and cardiothoracic patients. It's really, really important for them to understand, that because they are on immunosuppressive medication, the rules are a little bit different compared to what they can do or should do compared to what other people are doing. Also for my patients that I see who are, let's say, on immunosuppression, like if they have, let's say, if you have rheumatoid arthritis, or if you have, let's say, inflammatory bowel disease, like Crohn's disease or ulcerative colitis, those type of things definitely increases your risk of getting squamous cell because your immune system is just not working the way they should. So really important to know your risk in that sense. These are examples of squamous cell carcinoma. On the left cheek, it's almost like this horn buildup that you can see there. Almost looks like this this nail that's growing there. And then there's this patient on the right side with this poorly differentiated squamous cell carcinoma on the background of extensive. If you look at these lesions, these are extensive actinic keratosis and precancer. So it doesn't help that we just remove the squamous cell, because if we're going to just treat that area, unfortunately, the chances that he's going to get more is much higher. So we need to treat the squamous cell carcinoma, but we also need to make sure that we get rid of all of these precancers that he has. When I use my dermatoscope, this is the view that I see under the microscope when I look at that red spot. And suddenly you guys can see that these little blood vessels are much smaller. They're not so well focused. They look almost a little bit out of focus because they're much deeper. You can see here that it's ulcerated, so it's bleeding, a very sensitive area. And what happened was, at the end of the day, this patient had a large skin graft, and all those precancers were removed. Now, luckily, all around these areas, we've also treated him with topical field therapy to remove those lesions as well. So that is really, he did really well. Now, squamous cell carcinoma doesn't need to be as impressive as those photos that I've seen or that I've shown you guys, or even this one that you can see here. It also can be, quite subtle. Like if we look at this little red spot or that little red spot, this was a moderately differentiated invasive squamous cell carcinoma. This patient actually had a wide excision done and also had radiation. As well as this one, which is also an invasive, moderately to poorly differentiated squamous cell carcinoma. The one that she had here on her upper lip, the right side, this was an actinic keratosis. This was a pre-cancer that we just treated with local treatments. And then, of course, melanoma. There's 8 types of main melanomas that you get. First of all, your superficial spreading melanoma. Then you get your lentigo maligna melanoma, and those are the ones that's typically on the face, ears, and the scalp. You get nodular melanoma. Then you get acral lentiginous melanoma, which is on the palms of the hands and the soles of the feet. Subungual melanoma, which is all around the nail bed of the hands and the feet. Then you get your desmoplastic melanoma. Luckily, they're very rare, and they almost looks like a scar in older patients. Very difficult to diagnose, can be very tricky. Second last is your melanoma arising from a giant congenital nevus. So these are patients who have these really large birthmarks. So if you have a birthmark that's larger than 20 centimeters, so that's almost the size of a ruler, then you are at very high risk of getting melanoma. That's the only birth marks that we need to be concerned about, is if they're over 20 centimeters. And then the last one is melanoma in childhood, and luckily very rare, but of course always very concerning if you only even see one patient who has had melanoma as a child. This is where this is an example of a melanoma, and this is where I use my Mole Analyzer Pro. This is part of our full body photography system that we have, where I can use my Medicam, and this is, it's almost like a video dermoscopy, or it is video dermoscopy, where I can take a photo of the lesion. And then artificial intelligence can also help me by making a diagnosis. Now, this is an easy lesion. I mean, I don't have to get the opinion of artificial intelligence to make this diagnosis, because just clinically and looking at this lesion immediately, I can see that this is a melanoma, but it's always good to have a backup. And again, the artificial intelligence said that based on what is being presented here, it shows that there is an 82% risk of this being a melanoma. So this is really nice to have, and especially if I have lesions that I'm concerned about, it's always nice, as I said, to use the Medicam, and specifically the Mole Analyzer Pro, to see what the artificial intelligence is thinking about the lesion. So these are also 2 lesions. The first is this one was a lesion on a left forearm, and it was changing, and you can really see here that this area looked very different compared to this area. And this is where, again, if we talk about asymmetry, this is what we talk about. You can really see that the sizes, if you put a line here, this size doesn't look like this side, or a line through that side doesn't look like this side. So it looks very different. This was a very aggressive melanoma on a left forearm. I will show you guys a close-up just now. Raised, ugly looking. This doesn't look normal. You will immediately see here that this just doesn't look normal. And immediately, of course, patients or you guys will ask me, holy moly, I mean, how long has this patient been walking around with this lesion? And this patient probably had this lesion for about 3 weeks. So it literally just popped up and started growing like crazy. So this is melanoma. So again, not all these other things, you can immediately see, man, this is something that's just very obvious, looks very different, suspicious of melanoma. There's the lesion again, raised, ugly looking. This is a scab for bleeding. You can look at the brown all around. There's a raised area, that purple type of grayness to it. Very, very abnormal looking skin lesion that has metastasized. If I look under my microscope, my dermoscopic view, it's like this chaos. There's nothing nice and orderly around. You know, it's just the scale, this blue, gray. We call this a blue-white veil. Very, very, very indicative of a very aggressive melanoma that we're seeing here. This is a patient that presented for a lentigo maligna on the left ear. And this again, we can see that this brown, black type of lesion on the ear. And as I say, lentigo maligna, they're typically on the face and on the ear. But here we can also see, look at all this photo damaged skin and look at all these pre-cancers that's sitting there. So this patient is literally, his ear is covered in actinic keratosis. So there's a very good chance that in combination with the melanoma, that if we just leave this, that he will actually get squamous cell carcinoma as well. So it's not just the melanoma that we look at. Of course, you know, this one is the lesion that needs the most attention now, but that doesn't mean that we can just ignore the rest of the skin. This patient presented with a lesion. I examined him, and yes, that is number 13 that you're seeing. That was, 13 lesions. That was very abnormal. As soon as I got to his scalp, he said, "Oh, doc, don't worry about it. I've got this thing on my head. I bumped my head. It's just not healing. Don't worry about it. There's already a lot of other stuff on my skin that needs your attention. Don't worry about it." You can even see a little bit of pus there. And I was like, man, what is this? This looks really, really atypical. And after I descaled, I froze the area, I descaled it, immediately these two very, very, very advanced melanomas showed up. So again, if you have something that's not healing, something that even if you've bumped your head, it doesn't matter. Nothing is just going to stay there. You always need something. If something is not healing, then immediately we know something is wrong. And unfortunately, when I examined the patient, I also felt some lymph glands. So this means that the melanoma on his scalp has metastasized. It has spread to his lymph glands. And sometimes patients would ask me, how does it look if it's in your lymph gland? And this is how it looks. So it's like this round little ball that you can feel. And sometimes you can even see it without, you don't even have to feel it. So those are examples of metastases when it's spread from the scalp then to the neck area. Okay, this patient, who can see the melanoma? Who can see? There's a lot of stuff going on here on this patient's back. Who can see the melanoma? Let's give everybody just, I can actually have a quick drink of water. Perfect. Let's have a look. There we go. There's the melanoma. Very, very, very aggressive melanoma that is sitting here. We go back, there it is. But also when we just look at the patient, he's covered in moles. He's got a lot of moles. Immediately, this is one of the risk factors for developing melanoma. There's the melanoma, it's a big one. If we look under the microscope, this was actually the primary melanoma. And this one is what we call a satellite lesion. So this was already a small little metastasis. It's not part of this lesion. It's actually a small little metastasis of the lesion. So again, if we go up, there it is. It looks like it's part of it, but it isn't. There we go. We removed the lesion. Patient did really, really well. And then 8 months later, he presented again with a new lesion. Now, if you have a look here, this is a large lesion. He had a wide excision done, so it was a really, really big surgery, removed the whole lesion. And then what happened was, unfortunately, due to the tension on the wound, he had wound dehiscence. So that means the wound opened up. It took a long time for it to heal. And if you look closely, you'll see that the scar is actually from there to there. So that is the whole scar that it's got. And then what happened is this tumor developed in the scar. And when you see that the tumor developed in the scar, then you know immediately that this is, again, this is a metastasis, you know, and unfortunately, you know, he had to get more treatment. Then who is at risk? Now, phenotype, I always say sometimes it is all about looks. If you have a large number of moles, if you have more than 100 total body examination, if you have a family history of melanoma, specifically if there's more than one relative that has had melanoma or even non-melanoma skin cancers. Very, very important. If you're fair or pale skin that burns and does not tan, that propensity to freckle. If you freckle, especially when you were younger or now, it doesn't matter. But again, if you freckle, very, very good chance that you are at risk for getting skin cancer. Many large moles. And then very, very important, if you're a red hair or a strawberry blonde, personally or a family history, then really, really important that you need to remember your risk is really high. If you're a ginger or a redhead and you have more than 20 moles that is larger than 5 millimeters. Now, man, I mean, that's not a lot. I mean, 20 moles on your whole body that's larger than 5 millimeters, then you have a 25-fold increased risk of getting melanoma. So really important. So if you have a loved one, a friend, family member, really important. If you're redhead, pale, got more than 20 moles, make sure that they know about the risk. Tanning beds. Remember, ultraviolet radiation causes cancer. There's no way around it. That is just unfortunately a fact, and that is just the way it is. And tanning bed light is designed to mimic sunlight, specifically UVA and UVB. And UVB is the ray that causes burning, but it's actually UVA in tanning beds that causes damage, and it is 10 to 15 times greater than the sun. So it equals a UV index of 13, which is graded as extreme. And even more shocking is when you have a tanning bed with new bulbs, then it equals a UV index of 36. I mean, that is, yeah, I mean, how do you quantify that? 9% of Canadians use tanning beds, and this was proven or investigated by a Canadian Sun survey done in 2006 and 2012. Then all the parents, grade 12 students between 2006 and 2012, there was a double in tanning bed use from grad students from 11 to 21%. The first use of a tanning bed before the age of 35 increases your relative risk of getting melanoma with 60%. So again, yes, sunlight is a problem, but tanning beds is a huge problem. And that's why we need to do our best to get them banned, because there is nothing good about them. How do you clinically diagnose a skin cancer? Interestingly enough, you know, approximately 75% of melanomas are detected by patients themselves or someone close. Okay, so really, that's why it's so important to check your skin. And then, of course, we're going to look for the A, B, C, D, E, and I've made a short little video for you guys just to have a look. Hi there, you guys. This is Dr. Ben Wise at the Kelowna Skin Cancer Clinic. A question I get asked every day is, if I look at a mole, how do I know if this lesion is actually suspicious for bringing a melanoma. And this is where we use the ABCDE rule for diagnosing a melanoma. A stands for asymmetry. So if we look at the lesion and we would draw a line either horizontally or vertically through the lesion, and if we compare those sides, if we see that it's not the same, immediately we would say that this lesion is suspicious. B is for the border. So if the border is jagged or it's just very abnormal looking, immediately those are signs for an abnormal skin lesion. C is for color. So if we see quite a few colors in the lesion, browns, reds, blue, black, gray, those are all suspicious for a melanoma. Then D is the diameter. So if we see that the lesion is bigger than 6 millimeters, or it was small and now it has grown into a lesion larger than 6 millimeters, and 6 millimeters as a side that is about the size of a pencil eraser at the end of the pencil, that eraser larger than 6 millimeters, immediately that's a suspicious skin lesion. And then the last one is E, is evolving or evolution. So this means that we have a skin lesion and it's changing. It's changing in size, it's changing in color, it itches, it bleeds, it's quite irritated. Those are the characteristics that we look for an evolving or changing type of lesion. So those are the ABCDE rules for looking at your skin and helping yourself to know if the lesion is abnormal. And of course, if you are concerned, if you think that you have an abnormal skin lesion, make sure to see a physician that can help you with making the diagnosis and also helping you to manage your risk of possible skin cancer. Thanks for listening. Take care. So the next is dermoscopy. I mean, what is dermoscopy? So here on the left-hand side, this is a dermatoscope. So it's almost like a microscope that we use to look at the skin. And you guys, if you have had skin cancer, especially if you've had melanoma, you need to see a physician that is well trained in dermoscopy. You can't see somebody that's doing naked eye examinations. We've got great studies to show that your increases your accuracy of making a melanoma diagnosis with 27% compared to a naked eye examination. So we can't do naked eye examinations. It's really, really important that we need to use a dermatoscope. A dermatoscope for a skin cancer physician is almost like a stethoscope for a cardiologist. You can't practice without it, and you need some adequate training in using it. Dermoscopy, it's a magnifying glass 10 times with a very bright light, making use of polarized, non-polarized light. And this is where you look at the different features, as I showed you guys with the basal cell carcinoma. So it's almost like a jigsaw puzzle, where you look at all the different features, put it together, and then you actually get a diagnosis, a clinical diagnosis, and then of course we decide if we need to do a biopsy. Then a very interesting topic, full body photography. Now, full body photography, this is our unit here, it's my patient, and this is where we take photos of your whole body. It maps every little dot or spot on your body. So it doesn't just look at moles, but it looks at anything that is on your skin, and it will remember it. And then every 6 to 12 months, depending on your risk, this map is then compared to the next map. And then we use physician-guided artificial intelligence to identify new or changing lesions. It definitely increases the likelihood of finding new skin cancers, specifically melanoma or your pigmented skin lesions. It is definitely our most effective strategy to detect early melanomas, and really important, it also minimizes unnecessary excisions. Because again, for you guys who have had skin cancer, you know, the first time that something is removed, you might say, hey, scarring is okay, but after number 5 or 10 or 20, you know, you really get very tired of all these excisions unless it's really necessary. Then this is just I just want to show you guys a video of full body photography. Hi there, I'm Dr. Ben Wise, a primary care skin cancer physician at the Kelowna Skin Cancer Clinic. We are excited and very proud to be the first clinic in Canada to own the PhotoFinder ATVM Master, straight out of Germany. This is where total body photography and dermoscopy are married to create total body dermoscopy. It's not just about finding a skin cancer early, but absolutely at its earliest stage. Depending on your risk, total body dermoscopy will be done every 6 to 12 months. With the use of very sophisticated artificial intelligence, any suspicious, new, or changing skin lesions will be identified and presented to the physician in the new Mosaic view. This is true state-of-the-art technology, helping us with diagnosing suspicious skin lesions, but also monitoring our high-risk skin cancer patients. No wonder they call this unit the evolution of revolution. Perfect. So yeah, truly amazing technology, really helping us to make those diagnoses early of skin cancer. But then, of course, we need to ask the question, what does the evidence say about total body or full body photography? And interestingly enough, since 1982, Hagstrom advocated for serial total body photography, and this is where images were superimposed from projectors on top of each other to see if there were any changes. Because again, if you put those images on top of each other, and if there's anything new, anything changing, immediately you know that you've got a cancer. There is evidence that total body photography detects more in situ, so the earliest form or early invasive melanomas, and it was found that 38% of melanomas were detected exclusively or aided by total body photography. Melanomas are also detected earlier with the use of total body photography in high and very high risk patients. The tricky part about total body or full body photography is that there's no randomized controlled trials or large observational studies. So we definitely need more research into this field. We do know that there's multiple small retrospective studies that have showed that total body photography in high-risk individuals reduces biopsies. It also increases the detection of your very early stage melanoma, but there's still no clear evidence that it actually helps us to change survival. Now, again, this doesn't mean that it's not working. It just tells us that, you know, there's some shortfalls in our studies, and the question is just, you know, how much difference does it really make? I think what I see in my practice is, for my patients, is just to know that there's a copy of their, or a blueprint of their body or of their lesions, and that we can compare. They don't have to try to remember or try to take photos themselves, because I mean, that's people get my patients get very anxious, and that's understandable, you know, if you've had skin cancer. So in that sense, I think there's definitely psychologically, my patients who are doing full body photography, they tell me that they just do better overall, just knowing that they don't have to try to remember every spot on their body. Then the diagnosis, and again, there's different ways of making a diagnosis. And I think the most important point that I want to make here is when you have a suspicious skin lesion, the goal is to remove the whole lesion. You don't want to just take a small punch biopsy, punch out a small piece, because if you, by accident, the physician, take a punch biopsy from the area that is not representative, you're going to miss the diagnosis. So really, really important that we want to make sure that we remove the whole lesion. You can definitely use a shave biopsy, but a shave biopsy, unfortunately, is not going to tell you enough about how deep the lesion is. So yes, I do it also from time to time, but more on larger lesions. And again, unless you don't want to do a shave biopsy, you can also do an incisional biopsy, and this is where you remove a small piece inside the lesion. But an excisional biopsy, so you want to remove the whole lesion, that is the best way of making a diagnosis. Then of course we make the diagnosis, we send that to the pathologist, and then the pathologist will make the diagnosis. And there's two things that's really important: the type of melanoma, but much more important is the Breslow thickness, or the depth of the tumor of invasion, because this will immediately tell us if we need to further investigate these patients. If the lesion is more than 0.75 millimeters with two other risk factors like the mitotic rate, or if it's ulcerated, for instance, then we need to think about doing a possible sentinel lymph node biopsy. But as I say, the Breslow thickness is the most important considering factor on your histology report. It is a multidisciplinary team approach. This is where medical oncology, those guys, they prescribe the immunotherapy and chemotherapy if you need it. Radiation oncology, they prescribe the radiation. ENT, or head and neck surgery, they do the removal of the cancers for us. Plastic surgery, the reconstructive surgery, and then general surgery also, where they do wide excisions with the sentinel lymph node biopsies. So it's really everybody just working very closely together. And then of course the most important person from all of these are your family doctor, because your family doctor is your quarterback, who needs to make sure that they just organize and coordinate all your appointments and just having a close eye on your treatment. Then prevention. How do I make sure that I don't get skin cancer? Now, the responses usually at the start of prevention, the audience is very listening very closely, and then very soon it changes. Now, just to give you guys a little bit of background, these photos were probably taken, I almost want to say probably 10 seconds. There was a 10-second interval. When you have these little toddlers, the emotions changes very fast. But luckily also, even when they're crying, it changes also very fast again to being happy. So yeah, so these little guys, we have a lot of fun with them. Know your risk, but be mindful of your mental health risk. This is really important. Patients go through a lot of anxiety and stress when they're diagnosed with skin cancer, and this is where I love the Melanoma Network of Canada. They're awesome. These guys are doing just so much work at counseling, support, group networks. Participate, be part of them. People who are sharing their needs and worries, they just do better. So again, avoid ultraviolet radiation, specifically when the UV index is above 3. Now, just as a reminder, the tanning bed users, that is 11. So if we say when it's 3, just imagine now if it's 11. And as I say, they're also specifically between 11 and 3 p.m. Then also physical protection is always the best. UV protective clothing or UPF clothing, these are clothing specifically designed to keep you cool and protected. the minerals in the fabric radiates the UV rays away from your skin, and specifically making sure that your UVA doesn't penetrate deep into your skin. If you think about regular clothing, this is where you want to wear thicker clothing, where there's a tighter wave in the fabric, and also darker colors. And then when we look at sunglasses, UV filters, the wrap styles of larger frames, because 5 to 10% of skin cancers occur around the eyes, so high risk areas. Most people don't know this. All t-shirts are not designed equal. An average t-shirt that you got on, and that white cotton t-shirt, the UPA value is about 5 to 7, and when it's wet, it actually drops to 1. Now, this is where patients would tell me, but this is weird. Why do you say that? Because I don't burn when I have a white cotton t-shirt on. That is 100% correct. But it is the UVA that's not causing the burning, but it's actually the damage from the UVA that penetrates the cotton t-shirt. So your UPF shirt block 90% of your UVA and UVB, wet or dry. UPF is the UV protection specifically for clothing. As I've said before, that the UV protection clothing is infused with the fabric so that it never washes out. It's lightweight, stylish. It's luckily not like 20 years ago where it felt like you're wearing a piece of plastic. So again, if you can afford it, it's much, much more affordable to use UV protective clothing compared to sunscreen. And then sunscreen. Now, sunscreen was developed, interestingly enough, in 1928. Now, if you guys don't like sunscreen now, just imagine how sunscreen was in 1928. So when I read this, I thought, I think this is how those patients looked the first time after using that sunscreen. Have a look at this video. I might try it maybe once, like maybe it's not too bad. Then they decide maybe I'm gonna try this new sunscreen thing for a second time. And yeah, I don't like this. I don't like this. That is little Ruben, and I think that was the first time that he had pear, I think. And oh man, we had such a laugh at him with this video. So let's go on. How does sunscreen work? Sunscreens contain organic and inorganic compounds. They block ultraviolet radiation. Now remember, it's not like sitting in your basement in the dark when you have sunscreen on. It doesn't work that well. Sunscreen filters are active against UVA that penetrates deeper, and UVB that penetrates more superficial. So that's why they refer to sunscreen as broad spectrum, because it's UVA and UVB. Your physical sunscreens, those are your titanium dioxide, zinc oxide, and they reflect and refract the ultraviolet rays away from the skin. Your chemical sunscreens, oxybenzone, avobenzone, those are aromatic compounds. They absorb the high intensity UV light, and then the energy is converted to from a higher energy to a lower energy state, and that creates heat. How effective is sunscreen? What is the effectiveness of sunscreen in preventing photoaging? Now, photoaging include wrinkles, broken blood vessels, telangiectasia, pigmentation, and studies have shown that there's a 40% lower incidence in squamous cell carcinoma. That's really good. And those were people who were just using sunscreen by a discretionary basis. Definitely less, it doesn't work as well. Sunscreen doesn't work as well in skin cancer prevention as in squamous cell carcinoma, but it still prevents a certain amount of basal cell carcinoma. It significantly reduces the risk of invasive melanomas. And the bonus is that it arrests the signs of skin aging caused by photo damage. And it also significantly reduce the rates of actinic keratosis, which is the precursor or the preform of squamous cell carcinoma. So really important that we need to make use of a sunscreen, even though we might not like using it. How should sunscreen be applied? Most consumers typically under apply sunscreen with a standard use range of 20 to 50%. So most people don't use sunscreen correctly. So this translates into an SPF of 50, providing only an SPF of 25 in real life. Because when you are not using the right volume of sunscreen, then the SPF 50 suddenly dropped to 25. And that's why they say everywhere on sunscreen bottles, you'll see that they refer to it as apply sunscreen generously. Also, make sure to apply it 10 to 15 minutes before going outdoors. You don't get sunscreen that is waterproof. If you've been in the water, you need to reapply it. It is advisable that if you sweat it off, so let's say if you use sunscreen, so what I do is in the morning when I wake up, I put sunscreen on and I don't reapply my sunscreen. I just put it on once. But let's say it's a Saturday, I would go playing soccer with the boys outside, I start sweating, I go inside, I have lunch, and then I want to go outside again, then I'll reapply my sunscreen. But otherwise, if you don't sweat it off once a day, is definitely more than enough. Spray-on sunscreens, definitely less desirable because most of us, again, it's just inadequate with our application. And then, of course, there's also some studies that suggest that we might inhale it and it might be bad for our lungs. But again, sunscreen is not the issue. Sunscreen is not the discussion point. It is skin protection. That is the important thing to remember. What are the safety concerns in using sunscreen? Sunscreen can definitely cause some irritation, even without a rash. Rarely, but it definitely does cause some dermatitis from time to time. So some people just struggle to use sunscreen. And then, of course, there was those studies that showed that sunscreens are absorbed, especially your chemical sunscreens. But you guys, we need to remember there that this was for somebody or the participants who were using the maximum amount of sunscreen every day. Now, nobody's going to do that. I mean, it is just too messy. And then it shows up in your blood, but that also doesn't mean necessarily that you're going to get cancer. But as I say, the conversation shouldn't be about sunscreen. Cover up with clothing, and then whatever isn't covered with clothing, make sure to use sunscreen. And then, of course, some people say, well, I still don't like the idea of this chemical sunscreen being absorbed, or the chance that it might be absorbed. This is where your physical sunscreens literally just sits on the skin and it reflects the UV rays away. So if you don't like the idea of chemical sunscreens, then you can use a physical sunscreen. This is also very important, oral vitamin B3, nicotinamide, and then also Polypodium leukotomos extract. Now, when we talk about vitamin B3, it's not niacin. There is a difference between niacin and nicotinamide. Niacin is good for cholesterol, cardiovascular effects, but you want to search for nicotinamide. There's very limited side effects, and it is a bit of a silly dose because you need to take it twice a day, 500 milligrams twice a day for the rest of your life. Studies have shown that you can decrease your risk of getting basal and squamous cell with up to 30%, which it's not great, but it's still better than nothing. And then there's also studies to show that if you use Polypodium leukotomos extract, which is a fern native to Central and South America, that it can help in prevention of photo damage. But I need to tell you guys that this was very small randomized control studies, so not a lot of evidence about the fern, but definitely good studies to show that your niacinamide, the oral vitamin B3, definitely can make a difference. And of course, that doesn't mean you can go outside and bake in the sun. No, this is just another resource to tap into to try to decrease our risk of getting skin cancer. And then topical vitamin C and E, antioxidants. Really important to remember that sunscreens don't have antioxidants in. It's just not stable in there. So it's always a good idea in the morning before you put your sunscreen on is to use some vitamin C and E on your face because that's topically. Because that can definitely help with the oxidative stress that's also related in contributing to skin cancer. And then interestingly enough, also eating oily, fatty fish, not taking oral fish oils. So this is a few studies have showed that taking fish oils to prevent skin cancer is not going to help. In this case, you literally need to eat the fish, which is salmon, mackerel, tuna, herring, those really oily fish. 2 to 3 times a week. That's where you get the benefit of skin cancer reduction. Unfortunately, not by taking the supplementation. So this is where I discourage the use of taking oral fish oil. Rather have a nice salmon or tuna 2 to 3 times a week. And then to remember that we are all under the same sun. It doesn't matter how bleak things are, it doesn't matter how worried we are, we're all under the same sun, which means that we need to protect our skin. And as I say, remember, clothing is the best, and then whatever is not covered with clothing needs to have sunscreen on. And with that, I want to conclude and say thank you very much. It was awesome to chat to you guys.